Καλησπέρα σε όλους και όλες που για μια ακόμη φορά συνδεθήκατε για να ακούσουμε μια ακόμη ομιλία στα πλαίσια των μαθημάτων Υγεία και Θρησκεία. Σήμερα έχουμε μια εξαιρετική τιμή και μεγάλη χαρά να έχουμε ως κυρία εισηγήτρια την καθηγήτρια της ογκολογίας στην ιατρική σχολή του Harvard, Tracy Balboni. Είναι μεγάλη η τιμή να την έχουμε, διότι είναι από τους ηγέτες όχι μόνο στην επιστήμη της ογκολογίας στην ιατρική σχολή του Πανεπιστημίου του Harvard, αλλά και στην γενικότερη προσπάθεια που κάνει το τμήμα, η ομάδα των γιατρών του Harvard με το όνομα Harvard Initiative on Health, Spirituality and Religion, με το να οργανώνουν διεθνή συνέδρια πάνω στις σχέσεις μεταξύ υγείας, θρησκείας και πνευματικότητος. Η Professor Balboni έχει γράψει πάρα πολλά άρθρα και έχει πολύ σημαντικά βιβλία. Ξεκίνησε από το Πανεπιστήμιο του Stanford, μετά πήγε στο Harvard Medical School και τώρα είναι και στο Harvard School of Public Health. Δουλεύει ως ογκολόγος ακτινοθεραπεύτρια στο Brigham and Women's Hospital, όπως και στο Dana-Farber Cancer Institute, και έχει ιδιαίτερο ενδιαφέρον στα άτομα που είναι τελικού σταδίου. Για αυτήν την ομάδα έχει γράψει εκτεταμένα και έχει ασχοληθεί και κλινικά και ερευνητικά. Έχει, όπως είπαμε προηγουμένως, ιδιαίτερα ασχοληθεί τα τελευταία χρόνια για την σχέση που μπορεί να έχει η θρησκεία και η πνευματικότητα στα θέματα της υγείας και πόσο η πνευματική φροντίδα σε ένα ιατρικό περιβάλλον μπορεί να είναι χρήσιμο. Είναι διευθύντρια σε πολλά από τα προγράμματα τα οποία αναφέραμε και ο λόγος της, όπως θα δείτε σε λίγο, είναι πάρα πολύ, ας το πούμε, ευχάριστος και ουσιαστικός. Professor Balboni, thank you very much for joining us. I know what I said for you sounds Greek to you, but we are very grateful for your presence, and we are looking forward to listen to your presentation entitled Spirituality in Serious Illness and Health. Thank you very much. The floor is yours.
Thank you, Professor Linos. I so appreciate this opportunity to speak with you all, and it's really an honor to be a part of this course. And thank you to Professor Linos for your wonderful leadership of it. And I was just hearing about some of the other lectures that you have received and will be receiving, and it's really a comprehensive overview of all of the sort of facets of religion and health. Today, I'm going to be focusing a bit. My area of expertise is more in regard to an empirical lens on the role of spirituality in primarily serious illness. I am an oncologist, so I take care of cancer patients, so that's my sort of day-to-day practice, but we'll also spend some time considering the research on the role of spirituality within population health as well. And I'm just going to briefly provide some context for all of this. I'm sure this is all very familiar to you, but I think it's helpful to have even a reminder of that grounding as we consider the evidence regarding the role of spirituality, both in the context of serious illness and health. I do just want to provide some quick reference to definitions, which are already probably familiar to you all. This is Christina Pekulski and others' definition of spirituality, which, I won't read the whole thing to you here, but just point out some facets of it, including that it's dynamic, it's intrinsic. This definition would have that we all hold a spirituality. It's typically regarding ultimate meaning, purpose, transcendence, as well as relationships. And some various relationships are listed here, including to the significant or sacred, and that it's often expressed through beliefs, values, traditions, and practices. Religion is a related term that typically is understood as a communal form of a spirituality associated with common sort of traditions and practices. Other important terms that I just want to point out are is particularly relevant to the role of spirituality within healthcare are spiritual needs, needs related to a person's spirituality. For example, things like questions, concerns, the needs for practices, and then also frank struggles, as well as spiritual care, which within the context of medicine includes the recognition of and attention to spirituality within healthcare. So as I mentioned, the first part of this time together, I'm going to just provide a brief context of spirituality in medicine. This is probably a familiar photograph to you all. This is the Isle of Kos, the Asclepion. And I just include this photograph just to remind us of the context of medicine having been born in the context of spirituality. Of course, this is the place where Hippocrates was born, and where there was his teaching and medical school together with the worship of Asclepius. And so it just in many contexts, cultural contexts, the spirituality of that culture and the practice of medicine were done often together. There were ways that they were linked together. But that's changed over time, and particularly within Western contexts, beginning within the Enlightenment into postmodernism. We have the growth of materialism, this idea that all truth arrives from the study of the material world only. And of course, the empirical method becomes the primary way that we garner truths about ourselves, about humanity and medicine, along with many other sort of domains within knowledge, becomes really focused on, it has much more of a material focus than it had in the past. And that has important implications. And I just want to note this beautiful painting from an Enlightenment painter, William Blake, of Newton. Of course, this is the figure of Newton, pictured as a very muscular figure with much light extending between his eyes and the geometric forms below. Really signifying the beauty that comes from the study of the material world. There's so much good, so many ways that we can use our study of the material world to bring about good, including within medicine, the understanding of disease and how to bring about cures and alleviation of suffering, etc. But then it's important to note that all around this figure, including the very seat upon which the figure of Newton is seated, are these myriad forms that are sort of very difficult to characterize, sort of signifying, I think, that which lies outside of that sort of materialist gaze of Newton. The painter, I believe, kind of calling us to consider that is the seat upon which all our study of the material world is situated. And I just want to bring this to also our care of patients. So this is Anthony. It's not his real name, but it's someone that I was involved in the care of, a 57-year-old businessman with 2 young children, also had been an army veteran. He was very involved in his local religious community. He had blood in his stool and ultimately was found to have locally advanced rectal cancer. He underwent definitive management with chemoradiation and surgery, but then developed widespread metastases about a year after completion of his treatment. But for the next 6 years, he pursues many different cancer therapies. and even ultimately, multiple phase 1 clinical trials, flying to other countries to seek alternative therapies, really at quite a financial impact to his family, and even continues to pursue that care while dying. And this kind of, it just results in even some tensions within his family, because of his sort of relentless pursuit of care, even when it was very apparent to all that he was dying of his disease. His faith community really prays for healing over this time. And even though they begin to kind of see that he is nearing death, he continues to refuse talking, whether to his religious community leader, to his family, about preparing for death. And he dies soon thereafter. He had very recent chemotherapy, these sort of strained relationships and unmet spiritual needs. And this is per even just discussion from his with his wife, who really called that this experience was a very challenging experience that had lasting effects on their entire family. So that's one example of how, the medicine in this patient's case has really focused only on the material provision of care. And there's this deeper existential need on the part of Anthony that's not being met. And it's not being met by, certainly by the medical system, but even also by the spiritual community. There's this separation that's present. Or another patient who I got to know very well throughout her care, a 51-year-old woman. She's an energy healer with a new head and neck cancer. She underwent a surgical resection, and came to see me as part of post-operative management of her cancer. As part of a spiritual history, she described her energy healing community as her spirituality, and even explained that there are a lot of tensions for her because of pursuing more like what she called Western therapies, or sort of biomedical care, including the care that she was coming to me to discuss. She ultimately, her head and neck cancer locally did quite well, but then unfortunately she developed lung metastases a few years later, had aggressive management of these, but ultimately had continued progression. And I saw her again for management of painful pleural disease, and whether we could use sort of local therapies to mitigate her symptoms from that were keeping her. She had frequent hospitalizations because of this, but ultimately it wasn't felt that it would be helpful to her. But one thing that she said to me during one of these, sort of repeated hospitalizations, is how much she disliked being in the hospital. But she described it to me as, I can almost hear the people in the hospital, or hear it telling me that all I am is a body full of tumors that are killing me. And she went on to explain that what she was experiencing was they're just looking at my body. They don't see me. And it even sort of harkens back to that image of Newton that I described to you a moment ago, of only being seen for the disease, and that kind of being injurious to her as she was receiving her care. And I think this dynamic of separation also impacts clinicians. This is Paul Kalanithi, a neurosurgeon who wrote this book, When Breath Becomes Air. You may be familiar with it. But much of the book is about his training as a neurosurgeon. Unfortunately, he develops a metastatic cancer halfway through the book, that's described. And then we go into his experience as a patient. But in his description of becoming a neurosurgeon, he describes kind of his own experience of sort of the very materialist focus of providing care, and how he feels increasingly divorced from the larger kind of humanist realities of caring for patients. So, he describes that some days this is how it felt when I was in the hospital, trapped in an endless jungle summer, wet with sweat, the rain of tears of the families of the dying pouring down. I was losing sight of the singular importance of human relationships, not between patients and their families, but between doctor and patient. So he was feeling this sort of separation as he was from the patients he really aimed to embrace and care for as he traveled through his training. And you can just imagine that patients like, Anthony Kate, physicians like Paul Kalanithi, and other clinicians involved in the care of patients are kind of all in the same place, and yet experiencing this kind of division where, the spiritual is divorced from the physical. There's this relegation of kind of the spiritual larger realities to to out of view. They are not in view, and that creates issues for each one of those experiencing medical care, whether on the side of clinicians or of patients. So that's the context within which I want to begin speaking about the evidence regarding spirituality in both serious illness and health. And I'm going to be focusing on this paper because it provides an overview of the role of spirituality in these contexts. This came about because of growing research on spirituality in illness and health, but with little uptake into healthcare. And it's, often because some of this research there's doesn't necessarily get into high impact journals for various reasons. And though some of that may be related to the fact that though it's improving, there's some bias against the recognition of the role of spirituality in health. But there's some of that bias is decreasing. I believe you begin to see that even in the 1948 WHO definition of health, where health is understood as not merely the absence of disease or infirmity, but that involves other dimensions as well. They don't name the spiritual here. Later they do. You see that here in this 2002 definition, where they begin within their definition of palliative care to name the spiritual as one of the elements of health. So there's this increasing recognition that that health is holistic and has these multiple dimensions, including the spiritual. So what this project did was provide a comprehensive assessment of the literature on spirituality and health for patients facing illness, specifically serious illness, and then also within healthy populations. And then a Delphi panel was assembled to name the implications of that for the practice of medicine. This is the process that was undertaken. First, there was a systematic literature review where using search terms and various databases, all of these articles were collected. They were then screened by two persons for whether they met inclusion criteria. They were then extracted ultimately by two different individuals, and then ultimately they were summarized in a fashion that could be then digested by the expert panel. These were the systematic review starting in January of 2000 and going until May of 2022 yielded 441 serious illness papers. And that was after starting with over 15,000 papers. And for spirituality and population health, a total of 276 papers met inclusion criteria, and that was after reviewing over 12,000 papers. So what do we find from this literature? I said that the data were tabulated, and then each of the forms of evidence were placed under different sort of topic categories. This is a table from the paper regarding spirituality and serious illness and the literature here. So there were 5 evidence categories, such as the role of spirituality in serious illness, spiritual needs, spiritual care, spirituality and medical decision-making, and then ultimately spiritual interventions. These are sort of the numbers. We only reviewed and included as part of the evidence statements those with low to moderate risk of bias. These are the countries that are represented and their sample sizes. There were robustness criteria. So for example, they had to meet a certain sample size. They had to include validated spiritual measures, et cetera. And in order to ensure that these papers were of the most rigorous. So within serious illness, there were 8 findings deemed supported by strong evidence by our Delphi panel. Regarding patients, those were that religion or spirituality was important to most patients, spiritual needs are common, and spiritual care is frequently desired by patients. Also, religion, spirituality were noted to frequently play a role in medical decision making. And then finally, unaddressed spiritual needs are associated with poor patient quality of life outcomes. There were also some evidence statements supported by strong evidence that were more about the clinical care to patients. So spiritual needs are frequently unaddressed. So clinical caregivers aren't necessarily addressing these needs. Sort of a companion sort of finding is that spiritual care in general is infrequent. But when it is present, when medical systems, care systems provide spiritual care, patients with serious illness tend to have better end-of-life outcomes. So for example, quality of life and medical care outcomes. So I wanted to spend some time actually drilling down into these areas of findings and just provide you with examples of the literature, so you understand what's behind those evidence statements. I'll sort of frame it around some questions. So first is a study that addresses this question: is spirituality important within illness? And this is a large study of cancer survivors, so patients that had gone through treatment and were in remission or cured of their disease, over 8,000 of them. And My Faith or Spirituality Has Helped Me Through My Cancer Experience. That was named as the case quite a bit, or very much, by nearly 70% of patients. And this is a finding you see across many different contexts. Very similar numbers are found. This is another study which kind of helps to get into how spirituality is important within the context of serious illness. These are patients receiving palliative radiation for their cancers. Again, sort of a similar number we're finding, naming spirituality or religion as important. But then in this study, these patients were asked, well, how has spirituality been important to your illness? And then their answers were recorded and qualitatively analyzed. And the themes that arose were coping through one's spirituality, spiritual practices, spiritual beliefs, such as, sort of beliefs that are providing a framework for one's life and one's illness, spiritual transformation or a change in one's spiritual beliefs arising from the experience of the illness, and then the role of spiritual communities. So it's really functioning in multiple different ways for patients facing serious illness. So the next question is, is the relationship of spirituality to quality of life in illness? This is an older study, but it's been replicated kind of in various settings and with very similar findings. Over 1,600 cancer patients of all stages, spirituality measured with a validated FACIT-SP, and spirituality found to be an independent predictor of quality of life. And that's after controlling for many other sort of key predictors of well-being. So suggesting that spirituality is playing a key role in upholding well-being in the setting of a cancer. This is a related study, but looking at the question in a slightly different way. This was a study of over 1,800 seriously ill patients, all types of serious illness, and they were asked, what's most important to your well-being as you face your serious illness? And they called these attributes of quality of life near death. And they were provided 44. The top 9 were ranked in this paper. And number 1 and number 2 were being free from pain and being at peace with God. So of these 44, a spiritual construct, being at peace with God, kind of rising to the fore as being one of the most important contributors to quality of life, according to patients. So a next question I'd like to address is the role of spirituality in medical decision-making. This has been examined also by a number of studies. I'm just going to provide a few examples. This is a study of advanced lung cancer patients, their family caregiver, as well as the medical oncologist caring for lung cancer patients. And they were each asked to rank 7 factors important to the patient in making treatment decisions. These were the 7 factors. All 3 agreed that the ability of the treatment to cure the disease is number 1. So the patient's family member, the physicians all agreed that that was number 1 as far as impacting medical decision-making. But next, for both patients and families, the family caregiver, as well, was patients' faith in God. But this was the last of the 7 factors for physicians. So just illustrating how this is an important factor in patients' minds, as well as the family caregivers' minds, but not something that's being recognized as readily by physicians. But does patient spirituality actually impact medical decision-making? This study would suggest that it does. This is a prospective cohort study of cancer patients with advanced cancers, looking at baseline religious or spiritual coping and how it relates to receipt of care at the end of life. So if you'll recall in that qualitative study I mentioned to you before, coping was one of the, through one, spirituality was one of the main ways that spirituality functions in illness. This is a validated scale that was used, and patients were divided into high versus low religious coping, just with a median split. And this was the types of aggressive forms of care in the last week of life. And you can see that those exhibiting high religious coping received greater ventilation, greater resuscitation, and ultimately were more likely to die in an ICU setting. So suggesting that those relying upon their religious and spiritual beliefs to cope with their illness are actually receiving greater aggressive care at the end of life. Of course, this raises a number of questions. Why in the world would that be? This is a study of possible religious beliefs in end-of-life care that might be functioning and causing high religious coping patients to receive greater aggressive care. So, for example, my belief in God relieves me of needing to think about future medical decisions, sort of a deferment to one's sort of belief in God to so that you're not thinking about end-of-life decisions, or sort of sanctity of life being another issue. My faith tells me to do everything I can to stay alive longer. Another is miracles. And you can see that anything in the blue shade here is some degree of agreement. And majorities of patients are exhibiting agreement to these. Some other common ones were that of belief in a miracle, that God might cure me of my illness. In total, 87% of these patients endorsed at least one of these items, and just over 2/3 endorsed 3 or more items. So it's very common that patients can have sort of religious beliefs about that might be functioning in end-of-life care, might be influencing how they're making medical decisions. So a fourth question are there spiritual needs? And this is a study that addresses this, again, repeated in many other clinical and cultural contexts. This was performed in New York City, over 700 cancer outpatients, all stages of cancer. These were predominantly spiritual, not religious patients, which is sort of a, just a particular, a more frequent group, but this is particularly because I think we're in New York City, a higher number than in many other settings. But this was their spiritual needs assessment. This is a validated scale, and you can see across the board that these are very frequent, with nearly 80% endorsing at least one of these items. So again, just illustrating how frequent various spiritual needs can be in the setting of an illness. So next, let's consider spiritual needs and how they influence quality of life. This is a validated single item assessment of spiritual needs, and in particular, spiritual pain. So this is assessed with something analogous to our question about somatic pain. So are you experiencing spiritual pain? Spiritual pain is pain deep in your soul being that is not physical, assessed on a 1 to 10 scale. And spiritual pain was reported by a good number of patients, 44%, and it was associated with worse spiritual quality of life. So just suggesting that spiritual needs, particularly when they're resulting in kind of spiritual distress or spiritual pain, are associated with worse quality of life. So next, what about a fifth question and final question here we'll address is what about when we attend to patients' spiritual needs, when we provide spiritual care in the setting of illness, how does that impact outcomes for patients? This is a study of families who had been bereaved recently, so their family member had died. This was after high-risk surgical procedures. And they were asked, it was a qualitative analysis, so it was an interview study of what comprises good patient end-of-life care in reflecting on the death of their loved one. And these were the 4 factors that they named as key to patient quality of life at the end of life. Many of these, of course, I think make sense to us. Pain management, good symptom control, upholding dignity, Physical presence, loved ones in particular being present, and then a fourth was spiritual support. So spiritual support from all members caring for patients, including medical staff, and then the appropriate involvement of specialty spiritual care. Another study which examines this question and looks at outcomes of those receiving spiritual care is this prospective cohort study examining psychosocial and spiritual factors and how they relate to end-of-life outcomes. Spiritual care was assessed in 3 ways. Support of spiritual needs by the entire medical team. Patients assessed this at baseline. Support of spiritual needs by spiritual communities. And then also whether or not they're receiving specialty spiritual care visits. And then outcomes were quality of life and medical care received in the last week of life. So this was the quality of life findings at the end of life. So patients that reported spiritual needs as being present, and this, I'm just going to draw your attention here all the way to the right, because the blue here is any form of spiritual care has been reported. So any spiritual care is present. You can see these individuals have better quality of life at the end of life in adjusted analyses as compared to those receiving no spiritual care as part of their care. So suggesting that spiritual care is improving end of life quality of life. What about medical outcomes? High support from the spiritual team, from the medical team. Only 26% of patients reported that, but when it was present, they transitioned to hospice more frequently, they had less aggressive interventions, and were less likely to die in an ICU setting. And interestingly, the impact of medical team spiritual support on end-of-life care was largely seen in those high religious coping patients. Remember, I mentioned to you before that these are the patients that are at greater risk of receiving aggressive medical care at the end of life. Interestingly, high spiritual support from religious communities goes in the opposite direction. Those individuals tend to receive less hospice, greater aggressive interventions, and more ICU deaths, and our findings are stronger in our high religious coping patients. Suggesting, one possibility here is maybe it's those religious beliefs in end-of-life care that are being reinforced by religious communities, and perhaps that's why we're seeing this relationship. I just want to say a little bit about spiritual interventions and outcomes in serious illness. So there have been a variety of interventions that have been developed to improve spiritual well-being and quality of life among patients with spiritual illness, with serious illness. So one is meaning-centered psychotherapy. So this particular study was a randomized control trial comparing meaning-centered psychotherapy to supportive psychotherapy and enhanced usual care in over 400 patients. They were looking at outcomes of spiritual well-being, quality of life, as well as a number of secondary outcomes. Essentially, the provision of this spiritual intervention resulted in better spiritual well-being and better personal meaning. So just suggesting how this can be a powerful way of intervening and upholding spiritual well-being for patients. They also had a number of important secondary outcomes. So for example, less desire for hastened death, less anxiety, and improved personal meaning. So I just want to say a few words about spirituality and population health. Just a brief cursory overview of these findings. Like in the prior, this is table 2 from that paper. We have 5 categories of findings. They're sort of the main kind of evidence statements supported by strong evidence are noted here. And I'll just note that these include that frequent service attendance, so being involved in religious communities, is associated with lesser mortality. There's even sort of a dose-response relationship in that regard. So it's associated with longevity. There's also relationships to substance use issues. So for example, those frequently or heavily involved in spiritual communities have less smoking, use of alcohol, etc. And that's particularly the case among adolescents. There's also a number of important mental health, sort of quality of life outcomes. Those highly involved in spiritual communities tend to have better quality of life, better mental health outcomes, less depressive symptoms, and then less suicide. So a number of important behaviors. I'll just provide a few kind of examples of these findings. So for example, a meta-analysis of over 120,000 individuals found about a 27% reduction in all-cause mortality among individuals that were highly involved in religious communities. And then in addition to that, a number of important findings in mental health, about a quarter reduction in depression incidence, and a very large reduction in the incidence of completed suicide. So there's a number of, for population health, this is sort of pictorially just summarizing the many findings here, a number of ways in which being involved in spiritual communities is actually very important to, has important beneficial impacts to population health. So finally, within this study, the Delphi panel named the implications of these findings for the practice of medicine and public health. So in regard to medicine, these were sort of ranked in order of importance, and the top 3 are listed here. So within serious illness, they're recommending to be routinely including spiritual care in the medical care of patients with serious illness. The interdisciplinary medical team caring for seriously ill patients should be provided spiritual care education. And then finally, we need to be including specialty practitioners of spiritual care. So people professionally trained to provide spiritual care to patients within the care of patients with serious illness. In regard to health outcomes or population health, there's sort of a very similar analogous sort of findings regarding the implications of the evidence that I reviewed briefly with you. So first is that we need to be including within our population health interventions an awareness and attention to the fact that spirituality and particularly involvement in spiritual communities actually influences health. So this should shape our interventions to improve medical care and population health. We need to be providing education to particularly to public health professionals and those involved in various layers of the systems of public health. And then finally, we need to be recognizing spirituality as a social factor associated with health in research, also in community assessments, as well as program implementation. So really, I think some important implications of this, very strong evidence across medicine, from the care of the seriously ill to the care of communities of larger populations. So I just want to summarize here. We sort of had a whirlwind tour of the role of spirituality in serious illness and health. I sort of briefly provide the context that spirituality really has only been more recently separated from the practice of medicine and from healthcare more generally. And really the evidence supports that there should be an integration of spirituality into care. And for seriously ill patients, we're seeing that it's supporting quality of life. It also is clearly influencing medical decision-making. And so, and the data are suggesting that the integration of spiritual care actually could help to ensure more quality of life focused medical decision-making. Within the context of population health, we're seeing that the evidence supports integration of spirituality to support population health. We're seeing its benefits to sort of community longevity. Of course, there's a number of hypotheses as to why that's the case. Probably, if you look at mediational analyses, a lot of this are things like the social support that's generated by having a community around you. So for example, simple things like someone being able to drive you to your medical appointments, that's often provided by various spiritual communities. But when you look at mediational analysis, it's not just that. It's not just even health behaviors. That's another, health behaviors can also be impacted by communities, by spiritual communities. And when you look at mediational analysis, that does explain some of the variance but it's not all of it. And there must be there appears to be something greater. And it's probably, one wonders, the element of meaning, connection, a larger sense of purpose, et cetera, that's also influencing. Certainly we see it's influencing patient quality or even just person quality of life, mental health, et cetera. And that's influencing longevity. We talked about the ways in which it influences mental health, and then also has an important role in substance use prevention as well as substance use recovery for those struggling with substance use. So because of this, we really need further research in these areas and really models for practical application. Research that guides what should, the integration of attention to spiritual health look like in the public health setting? What should the integration of attention to spiritual health look like in the care of seriously ill patients? And, those are all questions which are really open questions. And I hope even those of you listening today might even consider perhaps that might be a direction you wish to go to begin to forge the research landscape further to help reintegrate spirituality into our care of populations and also of individuals facing illness. I just do want to take a moment. First, thank you to Professor Linos and to all of you for listening today. I also work with an entire team of individuals, and I won't take the time, we take too long to name them all. There's actually more that are just on the screen, but the research that I've been involved with, as well as that of others, is really behind much of what I've presented today, and I'm full of gratitude for that and for each one of them. And I do want to now open it up to a time for questions, and I'll stop sharing my screen.
Thank you, Professor Balboni, for this wonderful presentation and the many questions you put to the minds of the listeners. I have some few questions for you. I will try to translate from Greek. So the first one can be read as follows. Spirituality is a vast term, as you said. Do you think it has the same power, in quotes, as religiosity, and more specifically, the church community and Eucharist when dealing with health outcomes in serious illnesses?
Yeah. So it's a great question, and really is like a research question to some degree. I mean, I would say that, there are ways in which, and some of this you see within the population health research literature, although this is all kind of gleanings and really you would need further research to understand this further. But in the population health literature, the religious component is actually the strongest. So when I was, doing my brief overview of the literature in that regard, there many of those studies actually looked at more individual forms of spirituality. So spiritual practices or one's kind of spiritual well-being, things like that. And often it's not as strong as when it's present within a communal context. So one wonders is, yes, spirituality is important, and perhaps the more individual form of it is more important for certain aspects of well-being. But there are so for example, longevity and the longevity outcomes or substance use issues and recovery. It's the communal forms. And it's probably because for those particular outcomes, there are ways in which having a community of meaning around you, with practices like you described, like the Eucharist, et cetera, or whatever the case may be, depending on the religious tradition, that has a whole different dynamic that's more than just what an individual person can can themselves provide. Again, there probably are some kind of areas of quality of life well-being where the individual experience perhaps is more important, or but I think that there are the data, at least in the population health literature, would suggest that there's an element of the communal, therefore more religious aspect of practice that's actually really critical. It's a little harder to examine that in serious illness, because for seriously ill people, and this is actually a problem that I think needs to be addressed, it's often very much harder for them to be involved in religious communities because they're sick. I mean, so unless they're actually situated within a religious community, so it gets a little harder to disentangle involvement with a religious community from the fact that they're ill, and their illness is making it more difficult for them to be participating in a community. So
the next question reads as follows. Why, despite your studies, most people, and even more scientists and physicians, do not believe in God, are not faithful? What is your explanation? And do you think this attitude might change in the future, and how?
that's not an easy question. I'd love to have a discussion. I wish we could all have a discussion here about that question. I'm not sure how much of that is more an issue of definitions. So some argue that the secularism is itself a form of a religion. It has its own kind of telos, and which is typically just based here on Earth. It's very material. So it's kind of what one might call the religion around materialism. Again, some argue against that and say that's not the appropriate kind of understanding. But I think it is potentially helpful to understand that we all, if we're going to say spirituality, everyone has a spirituality. And there always are community structures around that spirituality. So the very individual, secularism is very individual. It's everything is here and now. There's nothing beyond. Anyway, we could, I'm not a theologian, or certainly, but many have argued that it's its own form of a religion. And it's I think a little bit helpful if we think about scientists, et cetera. So we are often acculturated, even though these are ultimately questions that we don't know for sure whether there's nothing after death, or, who can prove that? It's actually a faith commitment that's being made. I think that's the argument behind secularism being more of a more religious-like than, and therefore on the same playing field as any other religion. And definitely that sort of way, or that theology, if you want to call it a theology, predominates in scientific circles, certainly within the West. That's not, I do want to make the caveat that there are still many scientists, whether physicians or whatever the case may be, who are faithful people, that still ascribe to a faith tradition. But I think, maybe in part because medicine has become, and science in general, has become more of that materialist worldview that I mentioned at the beginning of the talk. There's this tendency for it to reinforce that way of seeing the world. And so you see, that's so common. Interestingly, in that book by Paul Kalanithi, who's, it's interesting how, he's getting sort of acculturated into this very materialist emphasis, and he's struggling with it and all the rest. He gets ill, and then when he faces illness, you see in the book how spirituality becomes, it's sort of a thread throughout the book. But as he's facing the end of his life, you see that kind of rise to the fore. So, and even I think a lot of questioning about sort of the secular worldview arises in that. So, so I agree. It's definitely a common kind of way of seeing the world. I think it would be helpful if there was more of an understanding that it is also a faith-based system. I think there's often not a recognition of the fact that it is. And yes, it tends to dominate the practice of many scientific fields, including the practice of medicine. But I think there should be more and more of a recognition of it as sort of it's just one of many worldviews that one can have. Because certainly one can have very much an appreciation for science and be a sort of traditionally religious person, and it can fit within your worldview as well. So secularism is just one of those worldviews, but not the only one that's consistent with science. Unfortunately, I think there's not a lot of recognition of that reality. I don't know if that helps, but
I think it helps. Now, the next question is similar. It says, do you have the feeling that your so important JAMA paper on spirituality in serious illness and health has influenced the general view by both physicians and patients that medicine is a total different area than religion? What is the impact of your paper in the medical and scientific community?
so I guess to some extent we're still kind of seeing it's still fairly early, although I guess it's now been 4 years or near 3.5 years since it was published. But I think of it more, all the paper did was just summarize what many other people have already done. So it just helped put it all together and kind of digest it all in a way that was understandable. And then of course, relying on the expertise of an expert panel helped to kind of present, okay, what does this mean for medicine? And so in some sense, a lot of this work it's already been happening. It's just kind of helping to bring it to the fore and in a way that's digestible and visible. So I think it's helped. It's been because it does that, because it helps for people to see and understand its reality. And I think all the work that was done prior to it by the many studies that have been done have already been helping people to see that this is actually an important entity for patients. So I think change has already been happening, and we still have a long ways to go. But I mean, little evidences I see, again, I don't think it was that paper in particular. I think it was that paper plus the many things that preceded it. So for example, for us within the US, the American Medical Association, the main organization, just named kind of the provision of spiritual care as one of its kind of areas of care quality, and certainly within naming it as important to education and also to practice. So there have been some, more and more kind of movements of accepting that this is a key element of health, and also a key element of how we educate clinical caregivers. But that being said, so I think there is some progress that's being made. I think this paper has helped together with much that has preceded it, and then the continued kind of research work that's happening now to continue to help to define what that means. I think that what this means, how this actually takes shape, because we haven't been doing this in the past, and people have a hard time knowing, well, how do I do this in practice? How do I make this a reality? Is really a key place where we need work to be done, and to continue to kind of help make it sort of a regular part of the practice of care.
And I think the last question, based on your specialty, what do you think about euthanasia, active euthanasia, especially in the patient with end-stage disease?
So, I mean, it's kind of a sort of different but related, I guess it's a related question. I mean, personally, as someone who is a person of faith, and in my own sort of context of my own beliefs, I don't believe that's consistent with, I don't believe it's consistent with my faith tradition. I don't even believe it's consistent with what medicine is meant to do. So, if there's, we have the first do no harm, like, and one could argue, well, it's not harm, you're actually helping. But as I'm also palliative care trained, and I believe that the answer isn't, well, I can't manage their symptoms. I can't uphold their dignity. I can't, so therefore I kill them. It's kind of like, I can't cure your cancer. So I'm just going to, just give you euthanasia. I mean, that makes no sense. So no, we provide better cures for cancer. We provide better palliative care. So that's the sort of coming from the grounding of my value. I would argue that those in support of euthanasia are also coming from a grounding of their value, and we need to name it as such. I think one of the issues is it's not being named for the fact that it is also a worldview and that's, again, it's largely coming from secularism, and sort of the values that are behind that. Anyways, but for me, I tend to be a sort of the thinking that we're extending beyond, certainly beyond my own kind of values and beliefs. So for me personally, but I believe we're extending beyond the values and that have undergirded medicine for millennia. And that is not something that should be violated. We need to do better as far as providing our care, not bringing about someone's demise.
Thank you so much, Professor Balboni, for your time and this wonderful information and advices you gave to all of us. Thank you so much. Have a nice day.
My pleasure. I hope you all have a wonderful day. Great to have this opportunity to be with you all.